Okay, so let's start with the next session concerning pancreatic neoplasia, and I would like to ask Professor Dubtsova for the first talk.
Thank you very much. Thank you very much. Уважаемые коллеги,
Dear colleagues, pancreatic cancer represents a huge problem. In the recent years, there is a gain in incidence as well as mortality related to this tumor. The highest mortality rate from pancreatic cancer is in Northern and Eastern Europe, up to 9 per 100,000 population. In Russia, there is an increase for over 10 years as by now, and the gain in incidence is 3.5 and 15%, and 15% in females. The mortality rate is 4.75 in males and 12% in females. Per 100,000 population. In the recent years, there are also trends of increased incidence of pancreatic cancer all over the world. In the United States, the pancreatic cancer is number 4 in the structure of oncological diseases, and according to prognosis, by 2013 it will be number 3 because of delayed diagnosis and inappropriate methods of treatment. The pancreatic cancer is a very aggressive tumor, and 5-year survival is no more than 6%. In patients with a resectable tumor treated in the reference center, the 5-year survival is as low as 25%. Therefore, the resistance of this tumor to chemo and radiotherapy worsens the prognosis of this disease even more. Why the prognosis is so unfavorable? It is because of the clinical picture. The tumors are very small, asymptomatic, and they're very hard to be diagnosed at earlier stages. However, these tumors could be effectively cured if diagnosed. The initial symptoms are inadequately estimated by the doctors: nausea, a loss of weight, changes of stools. These are very non-specific symptoms that do not cause cautiousness in the doctors. Besides, the patients may experience psychological inhibition, fatigue, a loss of body weight. But these are again very non-specific factors that do not cause cautiousness, oncological cautiousness in the doctors. And this is one of the most important reasons for late diagnosis of the pancreatic cancer. In 60% of cases, the tumor progresses, and after the minor symptoms, the first major symptoms develop. This is about mechanical jaundice that is not followed by the abdominal pain, which is more characteristic for cholelithiasis. The pancreatic cancer has risk factors as tobacco smoking, non-insulin-dependent diabetes, and some researchers point out that chronic pancreatitis increases the risks of pancreatic cancer by 20-folds. Diabetes of type 2 also poses additional risks for pancreatic cancer compared to the general population. A clinical case I wanted to show you as an example. A female of 52 was admitted to our hospital complaining of continuous pains in the epigastrium and worsening at night time. Past medical history revealed moderate hyperglycemia, 6.2 to 7, and palpation, a moderate tenderness in the right epigastric area. He has reported on pains syndrome for 3 months of moderate severity, however, without any hints to the doctors. On admittance, she was evaluated and masses in the pancreas were found. Fine needle biopsy was performed and cytology revealed adenocarcinoma of the pancreas. She was successfully operated on. However, it is worth noting that the spread of the cancer was quite severe. Progression of the tumor was noted, and later on the patient, despite of chemotherapy, died. The chronic pancreatitis may be caused by proliferative activity of acinar and luminal epithelium. Besides, reparation potential of the cells is impaired. Pancreatic epithelial neoplasia is formed that results in the tumor of the pancreas. Another example, a patient of 68 suffering from chronic pancreatitis as from 1980. In 1987, he was diagnosed with cholelithiasis. In 2007, diabetes of type 2. In 2014, intense pain was reported, and cystic shunt was found, or fistula was found. Later on, he complained of nausea and vomiting, and he was hospitalized many times. The CT scan, dated back to 2015, revealed calculous pancreatitis, pancreatic hypertension, and calculus cholecystitis. In 2017, he was referred to our center, and the CT revealed caudal masses in the pancreas with involvement of the duodenum, splenic vein, and the artery, secondary bilobar hepatic lesion, and calculus cholecystitis. He was followed up for many years, but pancreatic cancer finally appeared with caudal form, caudal localization. The patient complained of pain in the upper abdomen, initially related to the alcoholic excess, but nothing helped. He kept on losing weight. The blood biochemistry found cytolytic syndrome and cholestasis. He was differentiated for chronic pancreatitis and pancreatic cancer. Several fine needle biopsies, fine needle aspirations were done, but none revealed any positive material that was cautious for adenocarcinoma of the pancreas. However, after longer speculations and consultations, gastropancreatoduodenal resection was performed, and in the surgical specimen, a cytology of adenocarcinoma cytology was found. Therefore, underestimation of the tumor as well as improper diagnostics may result in improper treatment. Dynamic follow-up in case of the pancreatic cancer or pancreatoduodenal resection in patients that could be treated conservatively. The main goal besides differential diagnosis, was identifying potential resectability of the tumor. And evaluation of resectability is done with different ways. In our practice, there are two main methods. It is MSCT, that shows the distant metastasis, canceromatosis, as well as involvement of greater vessels, as well as ultrascopic ultrasound examination. Using ultrasonography, we can do fine needle aspiration of the tumor itself or the lymph nodes. Out of 220 cases of pancreatic cancer, we have less than half that turned out to be resectable, and a little more than half with non-resectable tumor. Clinically, the pancreatic cancer manifested with pain, and in patients with non-resectable pancreatic cancer and those with pancreatic head cancer, those manifested with mechanical jaundice. GPs, therapists, and gastroenterologists should always find an answer to the question what to do next. As long as there are no signs of unresectable tumor, we should refer the patients to the surgeon. But in case of metastasis, distant metastasis, canceromatosis, the case should be verified, and the patient should be referred to chemotherapy. However, there are errors related to the size of the tumor, age of the patient, and the level of oncological markers. Important is cooperation between chemotherapists, GPs, and gastroenterologists. The recent studies conducted in Germany and in the United States, California, it was demonstrated that tumors above 3 centimeters in size, or above 4 centimeters of size even, can be resectable. In the University of California, the tumor sized to 3 centimeters, 4 centimeters, and 5 centimeters in diameters comprise more than half of all the patients operated. Therefore, you should not refuse operating on the patient if you see huge tumors. Important is resectability of the tumor. Our experience is that even despite the tumor was above 30 millimeters in diameter, the patients could be successfully operated should the tumor be localized in the head or in the caudal localization on the tail of the pancreas. The cancerous embryonic antigen ONCA19-9 do not always correlate with the resectability, and you can use those oncomarkers as additional ways to diagnose the condition. You should actively search for oncomarkers as the index of your treatment efficacy, but they should not be used as a diagnostic.
The level of oncomarkers in patients was normal in half of them, and it was raised only in 1/3 of the patients. Therefore, the assessment of the efficacies are not good for the primary diagnostic. Speaking about the age of patients, there are data from books that no patients can be considered too old to be operated on the pancreatic cancer, and these patients are to be operated. We need to examine them, to assess them before the surgery, and the results of vital organs examination and it is safe for elderly patients to be operated on the pancreas. So the age of our successfully operated patients was from 39 to 83 years of age. Thus, to diagnose pancreatic cancer, we need to pay attention to the short anamnesis, to the newly developed diabetes mellitus in not very young patients, and to the mechanical yellow fever, jaundice. So we need to use we need to take into account all risk factors and the results of all trials conducted. As to the post-operative period, I want to say that after the operation on pancreas, the functional insufficiency develops as a endocrine insufficiency of the pancreas. By our data, after the pancreas of the resection, endocrine developed in the severe form. After distal resections, it was moderate severity state. But we need to compensate for this condition, because in the backdrop of endocrine insufficiency, we can see the steatory, the deficit of fat-soluble vitamins and others. That's why it is very often to provide replacement therapy for nutritive support. For the we need the assessment and correction of nutritive status before the operation, adequate enzyme replacement therapy before the operation, nutrition and nutritive support after the operation, then enzyme replacement therapy on a regular basis, and the control of the endocrine insufficiency correction. And the last thing I want to say, that most patients suffering from unresectable pancreatic cancer do not get enough enzymes, despite the fact that they have external secretory insufficiency. And if we do it, we can reduce the symptoms of insufficiency and improve the quality of life for these patients. That's why those patients who have pancreatic cancer should get enzymes in adequate doses. And it refers to both those who were operated and those who are unresectable. So, plus to diagnostics and treatment, the consistency is very important between doctors of different specialties. Only this will ensure good quality of life to our patients. Thank you for your attention.
Later on, so now I would like to ask Professor Khatkov. Maybe later. I think we first present. So I would like to ask Professor Khatkov to say the role of the surgeon. Sorry.
The European Association of Gastroenterology, Endoscopy and Nutrition, and many thanks for the choice of Moscow for this postgraduate course, and thanks to all the experts and opinion leaders, European opinion leaders in this area in gastroenterology. And I think that because my presentation is in English, perhaps I'll speak in Russian, because the most auditorium is Russian speaking. So, and I can make some explanations if they need in English. Yeah. So again, спасибо за.
Well, I thank you for the invitation, and my presentation is devoted to the tumors of pancreas and the role of the surgeon. And we have chosen the pancreas. heads that require good surgical work. Yeah, if we take the pancreatic head cancer, the results are very poor today. Although in recent years there have been a tendency for improvement, but for a lot of time, besides all the advances in gastroenterology, the overall survival was only on the level of 5%. Recently, it began to grow. And the 5-year survival after surgical operations reaches over 30% by the latest news. So we have some advances in the locally disseminated pancreatic cancer, in metastatic cancer. You see, look at the figures of the overall survival. Of course, it was done jointly by chemotherapists and surgeons. So my presentation is the role of the surgery, but I will focus on drug therapy as well, because only the combination of these two methods leads us to success. Speaking about the history, it started in the beginning of the last century, when the first operation was made. But the results were very poor for a very long time. So lethality was on the level of 20-40%, morbidity 40-60%, and overall 5-year overall survival only 5-6%. Then I would like to speak about Johns Hopkins Hospital. They give a lot of statistical data today. You see that centralization of patients for 10 years. They concentrated from 21 to 59% of all operations in their hospital, and they publish a lot of articles on their success. And this concentration allowed them to reduce the level of mortality from 30% in the 70s to 1%. They reported in 2006, and might say, we have a pancreatic club, and John Cameron will be here on the 13th of May, and he will be attended, and we will discuss the problems of the pancreatic cancer on the 13th of May this year. As to the changes that took place, you see that the improvement of this quality of surgery allowed to reduce lethality by 8%. The use of chemotherapy allowed to increase survival, and this combination of these methods allows to reach the 32% of 5-year-old survival. We haven't yet reached the required level, because the problems of early diagnostics are really outstanding. But now we don't have very many opportunities to detect pancreatic tumors at an early stage. So the main concept of surgical treatment today is to reach zero resection. Yeah, so to achieve resection when the edges are quite clear. There are very many morphological issues. Some morphologists consider that this opportunity by serious morphologists that attend to this meta. For example, Caroline Verbeek considers that this zero resection level cannot reach more than 20-some%. So surgeons are striving to reach resection within the healthy tissue. And the biggest problem is for border resection pancreatic cancer in border tumors, where there are certain criterion where this border and resectability is defined. This is relationship with vessels, suspicion of ingrowth, and massive coverage of the upper sigmoid. And in these situations where there are all surgical opportunities to make operations, including laparoscopic methods. Nevertheless, at present, these patients have a better result if they are referred to a neoadjuvant chemotherapy. First, they undergo treatment, and if there are some signs of stabilization or tumor regression, then a surgical treatment is done. So look at the use of this. Look at the use of this neoadjuvant chemotherapy. Look how they help to increase RO resection rate. So you see this neoadjuvant therapy allows it, as you see on this slide. So in all, you see that it can be up to, it can be improved up to increased up to 90%. The median survival is increasing for such patients. You see in vein and artery from 19 to 83 and to 25 in the second case. So the results of chemotherapy are very good, and there are a lot of papers that say not only bordering resectable tumors, but primary resectable tumors can be treated by neoadjuvant therapy. So these trials are made, and you see the results of the study in Netherlands. They show the improvement of the 2-year survival, the median survival in patients with primary resectable tumors who undergo neoadjuvant chemotherapy. There are 2 studies devoted to this problem here on the slide. And but it hasn't become yet a standard of treatment. And now I would like to switch over to operations, because the surgical method of treatment remains the basic for the radical treatment of such patients. And here the role of the what is the role of the surgeon? He can minimize danger and ensure the maximal comfortable period, a quick rehabilitation after the habilitation, and the beginning of the post-operative chemotherapy. And here laparoscopic methods allow us to reach it in many cases. A lot of studies have been made that show, probably for therapists it's not known, but for surgery there are very many discrepancies, discussions. In oncology they for a very long time doubted the possibility of using laparoscopic methods. But the pancreas was a good place for laparoscopic technique, and there have been very many studies, statistically significant, that since there are a lot of advantages, the lowered blood flow, for example, but there are no differences in post-operative complication and lethality. The only drawback is a longer duration of the operation. And you know, a lot of material has been collected for about laparoscopic operations, showing advantages of the method, like less blood loss, less POD, and there is no difference in the complication rate, mortality rate, overall survival. And the number of complications you see, even if it is extended operation with vessel resections, it is there is no difference in the complications, but there are advantages which I have just mentioned. Here I show. I would like to show the video. I can't do it. They must start simultaneously. Here I'm illustrating by this video. This is an illustration of laparoscopic methods. One is, you see the curve of the resection. You see how the tumor grew into the spleen confluence. And laparoscopic techniques allow to isolate the zone without any additional blood loss. And allows a very precision suturing of the defect that arises in the portal vein. Okay, everything is clear. Let us not dwell on it. It's just technical work. Let us now please show the second movie. As you see, the ingrowth is over 5 centimeters. You have to resect the area of 6 centimeters. You see the tumor is very well isolated. The blood loss is minimal. And on the whole, it has already been proven that a laparoscopic approach allows smaller blood loss. Here you see a synthetic prosthesis instead of the vein, heparin washing, and now there will be a final stage of the operation. Mostly there are therapists here. They don't see operations frequently, but if you have seen it once, you know that the picture is not different from what we see in open operations by all levels. As to oncological results, there is a large number of articles today that show that there is no difference in the median survival between laparoscopic and open surgeries. That also gives a way for increasing the number of laparoscopic operations, especially in high-flow medical centers. There is a number of meta-analyses that show the same results. Probably this is one of the largest meta-analyses, over 1,000 laparoscopic operations and over 8,000 open surgeries. This is Mayo Clinic. They compare laparoscopic and open surgeries and show in case of open surgery the delay of chemotherapy takes place 2 times higher than in case of laparoscopic operations. So you see here it is 12,000 patients they are operated that get chemotherapy, and there were some delays in getting chemotherapy by some patients. And these are the data of another study that show chemotherapy performance in another center. And you see the delays in the beginning of the chemotherapy. Sometimes the chemotherapy was performed with a delay of 59 days. That's why there is, of course, it shows the advantages of getting treatment in one medical center.
Therefore, in case of open laparoscopic intervention, it was also demonstrated no differences between the methods. The same is to illustrate that high flow reference centers, they are called here academic centers, demonstrate better results than low flow centers. Our results are reaching 400, and pancreatoduodenal resection was analyzed in nearly 300 patients. About 95%, 93% of operations are done laparoscopically, and here we see 80 interventions. Mostly these are adenocarcinoma, luminal adenocarcinoma of the pancreas. The other diseases are less prevalent and they are mostly benign. However, they are also indicated for laparoscopic surgery. The level of post-operative fistulas is compared to the high-volume centers, which is considered the most threatening complication, is 7%. Mortality is well above 1% compared to, for example, Johns Hopkins statistics of 1% that is reported also from the other centers, including so-called high-flow centers from Mayo Clinic, demonstrate 6% mortality. And in our center, the mortality was related to the poor general status of the patient that should not even be operated on. The same applies for long-term results. Our results are quite satisfactory because laparoscopically we have about 24% of 5 years survival. This is an honest, true percentage. Still, it can be improved using or implementing combination treatment options. The overall survival of patients with or without chemotherapy is not so different. Not all the patients underwent the complete chemotherapeutical cycle. Some finished prematurely, but still they are included in the chemotherapeutical group. The survival, median survival is dramatically lower, those not treated with neoadjuvant treatment. There are good achievements in chemotherapy, and FOLFIRINOX has added gemcitabine, which resulted in even twofold improvement of overall survival. However, this regimen is not applicable in all patients, and the results are quite good. I wanted to refer to the previous presentation to say that even in advanced cases, it is justified to verify the tumor even if surgery is not indicated in non-resectable cases. Surgery remains the main treatment modality in patients with pancreatic cancer. Laparoscopic methods can and should be used to treat these patients, however, better in high-flow centers, reference centers. We should also provide good or early onset of treatment, and the overall survival is the goal to develop new combination treatment methods. Neoadjuvant treatment should be used in arguably resectable tumors, and these patients should be only operated in high-flow centers. Thank you very much.
I understand Julia Mayerle is not present, so we skip this, or Marcus? You will speak.
But this is a different topic, so maybe we can have questions to pancreatic cancer.
Okay.
Because what I'm going to present is two things that are unrelated to
All right.
cancer. That,
Okay.
just
That's correct.
Differential diagnosis.
Okay, so time for questions. Do you have a question? Please, the microphone.
Спасибо большое за великолепный доклад.
Thank you very much for your nice overview. I refer to the speaker the first presentation. As you demonstrated, females that suffer from pancreatic cancer prevail, but one of the risk factors is tobacco smoking. Does it mean that women started smoking or even start alcohol abusing? What do you think? This is a very complicated issue. We have not conducted these studies. Tobacco smoking is considered as a independent risk factors, but it is not limited to the tobacco smoking in no way. The female presented to you didn't smoke, and the male did drink but never smoked. And my last question to you, if you permit, because females prevail in the pancreatic cancer and they also suffer from intestinal problems, do you think that it might be a risk factor causing pancreatic tumors? Neither these studies were conducted, and we have no personal experience in this respect. This should be. And gallbladder stone formation is another factor.
Please, Mark.
Two wonderful presentations. I want to pose a very provocative hypothesis to you. I think that surgery for pancreatic cancer is very mature now, technically. Even at Johns Hopkins, if I read their data correctly, since 1990, survival after surgery has not improved. That means that you have laparoscopic techniques which are less invasive, but they don't improve the outcome of surgery. My hypothesis, even if you go to marginally resectable, this will overall have no impact of survival on pancreatic cancer. What does have an enormous impact is centralization of surgery. You've shown the Netherlands data. Robert Gritzmann in Germany looked at data of survival after pancreatic surgery nationwide from insurance data. And the survival in Germany after pancreatic resection is the mortality is 10.8% nationwide. And half of the hospitals who operate on the pancreas don't even reach the minimum required 20 operations per year. And that's the effect the British and the Dutch had. In Great Britain, there is one pancreatic surgery for 5 million people, and no one else in no other hospital is permitted to lay his hands as a surgeon on the pancreas. And in Germany, we're way behind. We have too many hospitals. Everyone wants to do pancreatic surgery. Therefore, the dismal mortality rates. So I think that will be a big step. But if you look at the data, if you look at patients with advanced or metastasized, and you demonstrated these data very nicely, the median survival is 11 months with chemotherapy. That's the best we can reach right now with chemotherapy. With surgery, plus adjuvant chemotherapy, it's between 16 and 24 months. So if you only look at median survival, surgery is a palliative treatment for pancreatic cancer. With exceptional cases, you've shown your 25-27 survival rate after 5 years. Those are the lucky ones. And this has not been achieved by advances in surgery. This has been achieved by additional chemotherapy. So my hypothesis is twofold. We need to centralize services for pancreatic surgery, and we need a drug, because surgery has reached its limit in perfection. It will not further increase survival, but another drug or chemotherapy, which we haven't found, that will. That's my hypothesis to you.
Should I add something? I think that you're absolutely right, because we are simply struggling. And I think that all over the world, for centralization of this patient, you're absolutely right that the results are absolutely different in the high-volume hospitals and low-volume hospitals. And I think that 20 is not not enough, because we use 20 because in order not to push out a lot of hospitals from this kind of surgery, because all the surgeons want to operate it and so on. I think that normal figure is not less than 50, to my opinion, 50, 60 a year. Then you can form a team who understand how to manage the complications, because people are dying from complications that are not managed correctly in low-volume hospitals. It's very
That's
important.
a very important point. It's not the complication, it's how you manage the complication.
And I think in the whole, the decision of the problem of oncological disease, it's not lying in the area of surgery. It's in the area of therapy. But for today, we have no alternatives, and for pancreatic cancer, we don't. For example, for combined methods of treatment, we have 32%. In our case, for example, the 24% 5 years survival, but we not have such results in chemotherapy without surgery. So I think that for today, we have the possibility of only combined treatment, but we should move in finding some drug that will help for these patients. And another thing, of course, it's early detection. It's very important because it's influences. Because this 5 years survival for 32%, it's mostly it's early stages which are operated correctly and treated correctly.
Okay, thank you very much for this oncological part. Now we go to two non-oncological talks given by one person.
Yes,
autoimmune pancreatitis and case report of the pancreatic cyst.
Yes.
Marcus Lahr.
Julia Myla gives her best regards. Her whole hospital nursing staff went on strike. That's why she can't hear. She's pushing around beds. And that's why I'm giving you two presentations with a little break in between. And no, that's the second one. I think we start with the autoimmune pancreatitis. And I think they were put on the program because both are differential diagnoses to pancreatic cancer. And the one I'm going to start with is a very rare form of pancreatitis that quite commonly is confused with pancreatic cancer. Maybe you can give me the pointer or the thing. Thank you very much. And the disease is called autoimmune pancreatitis. The definition, it's a rare steroid-responsive autoinflammatory condition of the pancreas that often mimics pancreatic cancer. That's why we're talking about it today. And compared to all garden varieties of chronic pancreatitis, we don't even know whether it's a risk factor for pancreatic cancer, but it's definitely a differential diagnosis. And compared to all other forms of pancreatitis, it is responsive to steroids. So you can really heal these patients. That's why it's so important to know it. It's a fairly recent disease. The first description is actually from a German pathology in an obscure German language, East German paper. But the first who propagated the concept was the famous Marseille pancreatologist Henri Saul, who in the 1960s already reported a sclerosing form of pancreatitis without calcification that was accompanied by elevated immunoglobulin G levels in the blood. And it's only a little more than 20 years ago that the Japanese colleagues named Yoshida put forward the concept of this being an autoimmune disease which is distinct from all other forms of pancreatitis. It's much more common in Asia. That's why it's not surprising that most cases are reported from Japan, also from Korea, now from China. And we don't know much about the prevalence in Europe. I'm at one of the centers where patients are referred to, so my experience is about 30, 40 of these patients, but that's quite exceptional. Usually we think it's less than 1 in 100,000 population, so it's a rare form disease, but it's an important differential diagnosis. The symptoms are extremely unspecific. Some of these patients have epigastric pain. Most of them have these slight epigastric pain. It's much less pain than you have in acute pancreatitis, and it's much less pain than you have usually in chronic pancreatitis. to me, the major manifestations are diabetes mellitus and jaundice. And this is what the patient comes in, and that what also makes you, as you heard before, immediately think of a cancer diagnosis. And these are the things, if you look at resection specimens, and I'm only quoting here one study from the Netherlands, when they looked into all their patients' pathology who underwent Whipple's resection, they found that those who had benign disease, 3.3% of them had, in fact, autoimmune pancreatitis that was never diagnosed before. And the data are very similar. In Heidelberg, who looked at these data, so it is a differential diagnosis and is sometimes overlooked. There's no harm in having undergone pancreatic cancer, assumedly pancreatic cancer resection, and then turning out to have had autoimmune pancreatitis, because number one, most patients do better in their autoimmune pancreatitis. Number two, the patient doesn't have cancer, so he should be very happy that he has been misdiagnosed. My own boss, I trained with a surgeon in the US, was operated upon by his own mentor for pancreatic cancer and turned out to have autoimmune pancreatitis. This is the imaging presentation, and most of these patients don't come in with imaging of a cancer, but with a diffusely enlarged pancreas on CT scan. And something is very specific. They usually have an enhanced rim around this enlarged pancreatic organ, and that should also alert you to this being a possible case of autoimmune pancreatitis. They also have specific ERCP changes with long stenosis and side branches coming out of the stenosis, which you never see in cancer or other forms of pancreatitis, but I don't want to go too much into detail. The same is true for MRI. It's a diffuse, unspecific enlargement, and it does lead to a capsule-like ring. We tried to look into endoscopic ultrasound is the mainstay of diagnosis, because this is where you take your biopsy. And you cannot really properly diagnose autoimmune pancreatitis without taking a fine needle, 20-gauge needle biopsy from the pancreas. I'm going to show you later. We try to replace that with elastography of the pancreas, and we published the data. It simply doesn't work. Elastography is not helpful. However, EUS-guided fine needle aspiration, and you get this type of cylinders where the pathologist really can make a diagnosis, is absolutely crucial to differentiate. And to differentiate not only from cancer, but also because there are two types of autoimmune pancreatitis. And we thought this was the same disease, and we had many consensus conferences before the Japanese accepted that there is a non-type A type of autoimmune pancreatitis. The type 1 is what you usually find in Japan, and this is always correlated with IgG4 positive plasma cells in the tissue specimen and with raised IgG4 levels in the serum. That's the important biomarker. It's not a very good biomarker, but it's the best we have. If we have 3 times elevated IgG4 levels in the plasma, that's very indicative, with a lot of other details I can't get into, for type 1 autoimmune pancreatitis, and it's part of a bigger IgG4-related disease, which includes the bile duct, which can include the lungs, which can include the kidney, which can include the glands in your mouth, salivary glands. Very common to have it in the salivary glands, in the thyroid, to have retroperitoneal fibrosis. This is IgG4-related syndrome, and autoimmune pancreatitis type 1 is part of that. The type 2 is much more difficult because there's no blood test for it. You have to have histology, and cytology doesn't do. It has to be a cylinder from the 22-gauge needle. They have a characteristic granulocytic epithelial lesions. A pathologist will immediately recognize what this is. This is neutrophils inside a duct. Those you mostly find in autoimmune pancreatitis type 2, and they're absolutely characteristic for this type of disease. This is taken from a case who turned out then to have pancreatic cancer, hence the differential diagnosis, but this is what the pathologist is looking for. So other organs are involved, and the steroid responsiveness is quite differently. I'm showing this slide because you see that in addition to the pancreas, in the type 1, you have involvement of the biliary system, not only the pancreas, also the salivary glands, the lungs, the lymphadenopathy, retroperitoneal, kidneys are sometimes, and in type 2, you practically never have recurrences. Once you treat the patient, he's cured. In type 1, you have a high degree of recurrences, and even after successful steroid treatment. This is a very negative view on this. If you treat them with steroids, 89% will have complete remission of autoimmune pancreatitis. The problem is, if you don't treat them, 2/3 even get remissions without treatment. That makes it so difficult to distinguish from other forms of pancreatitis and to make the decision. But one thing is very clear: you can, even if you can't clarify the diagnosis, a probatory treatment is legitimate. If it's reduced, it's not a cancer, and you can always, if in doubt, and you cannot get histology, treat the patients for 2 weeks with steroids, and he should respond if he has autoimmune pancreatitis. What about the recurrence rate? And this was a statistic by Dr. Kamisawa that mixed type 1 and type 2. The relapse rates under steroids are 24%. Without steroids, they are 42%. Again, an indication to use steroids in this patient. And this is the only study that has systematically addressed the question, should they be on long-term treatment? And Atsuki Masamune compared two groups. I mean, this took years to collect these patients, 131 patients. It couldn't have been done in Europe. It could only be done in Japan because they have a much higher prevalence. They compared tapering off compared to long-term 2 years use of 5% prednisolone, and the answer is very clear. The recurrence rate is not perfect, even under the relapse rate under a long-term treatment with steroids, but if you stop the treatment, then it's much worse, and half of the patients will relapse. So the answer is very clear. We taper off after 4 weeks the treatment with steroids, and we continue them for at least 2 years below the Cushing threshold level of 5 milligram. There's one other treatment available. It's questionable whether other immunomodulators are really effective. We use azathioprine without much evidence, but one thing is very clear: in those that are not steroid responsive, although that do recur, you can always use steroids again, but if they then are unresponsive, you can use rituximab, and that is a very effective treatment. This is my summary for the autoimmune pancreatitis part. Autoimmune pancreatitis is a rare disease of the pancreas that sometimes mimics pancreatic cancer. About 3% of those operated upon and turn out to have a benign disease do have autoimmune pancreatitis. There are two subtypes. Only subtype 1 has a biomarker in terms of IgG4 elevations. The other one has not, and you do need histology. Steroids are highly effective for both types. And you do need maintenance therapy for type 1, not for type 2, because they very rarely recur. Immune modulators may be effective. We use them. Rituximab is highly effective, but very expensive. You need to talk to the insurance company, and relapse of type 2 is very rare. And this is the finishing slide of Julia's hospital, where she's just sitting and pushing around beds and trying to replace nurses. Thank you very much for this.
Great talk, also within the time, but I think I would like to ask you to continue, and then we discuss after that.
Okay. So the other presentation I had prepared, I was asked to prepare a case with a pancreatic cyst. And I think, Igor, in your hospital, you do more resections now for these doubtful pancreatic cystic tumors than you do for actual pancreatic cancers. At least that's what Marcus Buchler and Claudio Bassi tell me, that they have an enormous increase since we know about IPMN in patients with suspicious pancreatic cysts, and this is what I'm going to show you as the next case. And this is the case I borrowed from Marcus Buchler because we both discussed him extensively, and we both have very different interpretations about this case. This is my hospital, by the way. It's a 500-year-old university with a very new hospital, and we're right on the beach from Riga. Where are you? So this is a 61-year-old patient. It's quite common. It's a very simple case. And he had, for whatever reason, a CT scan, a not very good CT scan, and he didn't have it in Germany, but in another country. And he had an incidental finding of a pancreatic cyst. And this is the CT scan. And what it shows you, maybe I can probably best show, no, the wall reflects. You can't, there is the, right in the middle. I can't use the pointer, unfortunately, because it reflects on the surface. Maybe I can show it there. No, it doesn't work on the monitor. I don't have a mouse. So almost in the center, a little to the left, you see a small cyst, and the differential diagnosis was, could this be a duodenal diverticulum? Or could this be a cyst in the pancreas? And the doctors in that country said, well, we control it. So the patient comes back 2 years later, and again, this time he has a little better CT and a little larger cyst. And the doctor says, well, it's a cyst, it looks like a cyst, we're not going to do much about it. And this is 5 years. So it's a very long observation time. The cyst has somewhat increased in size. It's now at least it's marked. It's a little over 3 centimeters. And you see in the center a little nodule. And the little nodule was the reason why the surgeon decided, well, this is suspicious. I'm going to show you why, and we have to take it out. The patient was operated upon. And before the operation, they did what one should do. They did an endoscopic ultrasound as a second imaging procedure. They stuck a needle into the cyst, and they measured CEA and CA99. Why the hell they measured CA99, I don't know. You don't measure CA99 in cysts. It only confuses everyone because it's always very high. You do CA99 in the serum of patients because this will tell you whether the patient either has cancer or, even better, irresectable cancer. It's a terrible tumor marker. But in a situation like this, it's not used for screening, but it tells you if this was a blood level, you would know this patient has irresectable pancreatic cancer. They did it in the cyst, it doesn't tell you anything. The CEA, however, if it's over 200, it tells you not that it's a malignant cyst, it tells you that it's a mucinous cyst and not a serous cyst. Serous cysts are harmless, mucinous cysts can be pre-malignant. The level, whether it's high or low, doesn't tell you whether this is a malignant tumor or not. Never confuse that. But the cytology taken from the cyst and from the nodule told you suspicious of high-grade dysplasia. So the patient was operated upon, he underwent a Kausch-Whipple procedure, and it turned out he had a 1.8 centimeter pancreatic ductal adenocarcinoma, which was like already a 1C with one lymph node, so it's advanced disease, with infiltration, not in the vessel, but in the lymph nodes, and he then received adjuvant chemotherapy. And this case shows you the whole dilemma of how long can you follow a cyst, how long is a cyst harmless, and we did some studies, and particularly, what do you do with this type of cyst? And this is not uncommon. This is a patient with multiple branch duct IPMNs, and this is not cured by taking one cyst out. It also shows you this image, that this is a field effect. Even if you successfully operate on such a patient and take the cyst out, the rest of the pancreas still, without getting cysts, has an increased rate of developing pancreatic cancer, and that's called a field effect. So the patients never get out of surveillance, even if operated upon successfully. We did, I already mentioned this morning, a population-based study we do in Greifswald, which is very similar to the Framingham project. And from these 5,000, we selected 1,000 patients who underwent a whole body magnetic resonance imaging with a focus on the pancreas and secretine-stimulated MRCP, because we wanted to know how common are cysts in the general population. None of these patients ever had pancreatitis. We excluded all with a history of pancreatitis or with a history of pancreatic disease. And the results are quite surprising. Half of the general population has cysts in the pancreas with a size of more than 2 millimeters. Well, maybe 2 millimeters is not relevant because there's a lot of cysts, and also the number is quite interesting. Between 1 and 5 cysts were found in more than 80% of these who did have cysts, and more than 20 were found in almost 2%, more than 11 to 20, more than 10 were found in 3%. So it's not only common to have cysts in half the population, to have several cysts in the population is also quite common. The most relevant is probably the size. If you only look at those over 1 centimeters, the numbers of course go down to 5%. But it's 5% of the population who have cysts with more than 1 centimeters, and those are probably the only ones that are really clinically relevant. So we had follow-up data of a part of these, and the interesting thing is some cysts got larger, some cysts got smaller, and some developed new cysts. About half of those participants either developed new cysts during the follow-up period, or their all pre-existing cyst increased in size. So this is what you're most concerned about. There's a new cyst or there's a larger cyst. However, not a single patient developed pancreatic cancer. And that shows you that it's a common problem, but not one that invariably leads to a serious disease. So what guidelines should you follow? There are many guidelines out there, and probably the most relevant, I say this because I was involved in that one, is the European guideline that just came out last May in gut. But the recommendations are generally quite similar, with the sole exception of the American ACG guideline, who are much more conservative and have a lot of insurance issue raised because now insurances no longer pay for the follow-up examinations. So I don't think that's a very good guideline. What are these cysts? And there is a lot of possibilities if you have a cyst in the pancreas. This is the complete list. And I think we can focus on these two ones because these are the pre-malignant ones. It's intraductal papillary mucinous neoplasm. That's the IPMN I refer to, which, by the way, also exists in the bile duct as a separate entity. And it's the mucinous cystic neoplasm. Both of them are pre-malignant. Both of them are kind of related. And just below them, you see the serous cystic neoplasm that are completely harmless. And there's a series by Philip Levy out with more than 1,000 of serous cystic neoplasm. They practically never turn into cancer. And they also don't have CEA inside the cystic fluid. How common are these? I show you how common cysts are in the population. How common are cysts in patients? And that depends on whether you look at a patient's registry or as a surgical resection registry. The green ones are the ones that have been resected, and the blue ones are the ones that were in a clinical registry, and they're almost the same, with the exception that mucinous cystic adenomas are found more commonly, and rightfully so, in the resection specimen. What worries me a little is that the serous cystic adenomas, the harmless one, are almost as often resected as the mucinous one, which are pre-malignant. So we haven't learned very much in our registry or our handling of cases from these things. So if you see a cyst, you should ask 3 crucial questions. Number 1, is this an incidental finding or does the patient have symptoms? That's not an easy question because everyone has these weird low-level abdominal discomfort sometimes, but if the patient has pain, that is really an indication for treatment. The other two questions are, is this a mucinous lesion or a serous lesion? The serous lesions are harmless, and you can only distinguish them by sticking a needle into the cyst by endoscopic ultrasound. And what you always measure is CEA and not CA99 in the cyst, CEA. If it's up, it's a mucinous lesion. It doesn't tell you if it's malignant or not. You always measure lipase because only pancreatic pseudocysts have lipase in them and sometimes IPMN. You always do cytology, mucin, and there's some specialized things I don't want to get too much into. And the question is, does the cyst have communication with the duct system? And the best way to find that out is secretin-stimulated MRCP. Because if it communicates with the ducts, it's either a pseudocyst that's easily distinguished or it's an IPMN. And this is the current algorithm that's very similar in the Japanese, the international and the European guideline. What you also look for is two things. One is the size of the cyst. The smaller the cyst, below 1 centimeter, you control after 6 months and then after 2 years if it doesn't change. If it's above 3 centimeter, your intervals of control are much, much shorter to see whether nodules arrive. The other thing you look for is high-risk stigmata or worrisome features. Both are relevant for the decision to operate on these patients. We're not talking main duct IPMNs. Those should always be operated if possible. But the branch duct IPMNs should be operated when there are high-risk stigmata, which include obstructive jaundice caused by the lesion, enhancing mural nodules, contrast-enhancing mural nodules over 5 centimeter, or if the main duct is over 10 millimeters and compromised. Those patients should undergo an operation. If they have, this is the lesser degree, worrisome features, the same is true, and this is again smaller enhancing nodules, the thickening enhancing cyst wall, a main duct between 5 and 9 millimeter, abrupt changes in caliber of the pancreatic duct with distal atrophy, suggestive of cancer, lymphadenopathy, increased levels of serum levels of CA99, and if the cyst grows. And I think this brings me to the conclusion, and this is the team I work with, and Julia Mayala, who was part of the team until 2 years ago. Thank you very much for your attention.
Thank you very much. Questions? If I may start, the patients are really afraid of pancreatic cancer. So if you have a patient with a small cyst, how do you discuss with the patients? How do you give arguments? Because I found it quite difficult to convince the patient that there is no worries, but they are, going to another doctor, and they find in the end surgeon who will operate.
Right. Well, I tell them about the surgery data from Robert Grützmann, that the mortality after surgery is 10.8%. And then they're much more scared of the surgeon than they are of the less than 1 centimeter. Sorry, Igor, for saying that.
You don't advertise the surgeons, I understood.
Right. And even in the best of centers, they are, like you showed us, they're between 3 and 5%. And the morbidity rate is 30%. So they're usually comforted if you say, well, this is probably a harmless cyst. Let's look at it again by endoscopic ultrasound 6 months from now. They come back after, I have patients looked after for 5 years. After 5 years, they get tired. Their treating physician gets tired and the patient gets tired. I said, what are all these follow-ups about? Either take it out or leave me alone. And then I say, well, maybe we'll leave you alone. You're now over 88 years old. We have controlled long enough. You're not going to see this. A main duct IPMN takes 7 years to turn into a cancer. You have to know that. And the one I've shown you from Marcus Büchler's practice took 5 years to turn into a cancer. That should have been operated earlier. There's no question about it. But I think the Fukuoka guidelines and the European guidelines are very valid, and they have been shown by Italian surgeons to be valid and to not miss cases with pancreatic cancer.
Okay,
I have the same questions more about autoimmune pancreatitis, because what concerning cystic lesions, it's more or less is understandable for the surgeons, and this question is discussed on all surgical congresses and so on, and it's simply interesting your tactics in autoimmune pancreatitis. When you are treating the patient for 2 years, as I understand, with some drug, I know, how you make the observation on this area in order not to пропустить.
To miss the cancer?
Yes, not to miss the
Okay.
cancer.
Well, I was raised by a
you
surgeon.
afraid
I'm a
of this?
gastroenterologist, and I'm very pro-surgery. So I think that with all imaging techniques, you still have a rate where you see a tumor. You still have a rate of being 20 and 30% of patients where you cannot definitely say whether exclude pancreatic cancer. And if in doubt, cut it out. If the patient is healthy enough, if the patient doesn't have other risk factors, I'm still in favor of surgery in questionable cases. And you have to accept this 3% false rate. You have to think about autoimmune pancreatitis. You have to do biopsy of the autoimmune pancreatitis. I have in my practice 2 or 3 cases where we thought it was autoimmune pancreatitis, where we treated the patient for 2 weeks with steroids. There was no change. And we even had the gels, which are indicative of autoimmune pancreatitis. Patient didn't improve. 4 weeks later, he had a surgery, and bam, it was small pancreatic cancer. So if in doubt, do the surgery, because, I mean, it's very easy to make the diagnosis of pancreatic cancer if the patient has advanced disease or metastasized disease. The difficult ones are the 1 centimeter, 2 centimeter lesions, and they can be mimicked by autoimmune pancreatitis. And we know from a case series from Japan that these patients, even in respect to their autoimmune pancreatitis, they do better when they had surgery, if they survive the surgery, which they should.
A practical question. If you give for 2 weeks the steroids, what do you expect? It to disappear completely, the enlargement? How half of it effect?
The pancreas
or
gets
a little
smaller.
bit? Just
Yeah.
get smaller.
It gets smaller.
So another question, the cancer will never diminish after steroids?
That's, well, some do.
Some do, yes.
You see, but the ductal changes don't disappear in the cancer.
Okay.
And the ductal changes do disappear in autoimmune pancreatitis. And there's one study from Dr. Kim who has shown that even for 4 weeks, you don't lose anything by delaying surgery for 4 weeks, but you fish out a number of autoimmune pancreatitis cases that are then no longer do need surgery. So it's legitimate even in the guidelines to say, well, if you can't solve it, give them 2 or 4 weeks of steroids, see what happens, and then make the decision to go to surgery. And I personally have 3 cases where we did that, and the cancer was resected in time.
And a practical question about the waiting time for surgery for pancreatic cancer. Is it shorter than 2 weeks or just?
Usually in Germany, it's no problem to get pancreatic surgery between 2 and 4 weeks after diagnosis. You see, because we have too many hospitals, too many people will do the surgery, so we're on the other side of the spectrum.
And waiting time for your surgery is in Moscow?
It depends, because unfortunately we don't see not majority of our patients are with benign lesions and with cysts for today, because unfortunately we have a lot of patients in advanced stages of pancreatic cancer, so we have a lot of patients with jaundice. So I saw if I'm not mistaken in figures, we have about 80 with something percentages of people who had jaundice who had to be drained. So if the level of bilirubin is very high before the operation, we should wait, and we're waiting up the bilirubin goes lower than level of 80. So we have some time for this, and sometimes it takes not 1 week, it may be even several months sometimes. Okay. But usually it's 2-4 weeks. If we make the diagnosis, we don't wait too much. I think it's several weeks.
Okay, if no more questions or comments, there is a break. Yes, 10 minutes? 10 minutes break. So we meet again at 16:25.
Sorry, can I ask you what dosage of